Picture this. It's 7:30 in the evening. You're watching television, comfortable, relaxed. And then you're gone, asleep on the couch before the program even ends. Your family might joke about it. You might laugh it off yourself. But then 3 in the morning arrives and you're wide awake, completely, stubbornly, infuriatingly awake. Your brain has decided the night is over, even though the rest of the world is still hours from sunrise. You lie there running through the same thoughts, watching the clock, waiting for a sleep that isn't coming back. If that pattern sounds familiar, here is what you need to know. That's not just getting older, that's a specific, well-documented shift in your circadian biology, and it has a name, a mechanism, and a set of targeted solutions that most people have never heard of. The changes that happen to sleep as we age are real. Melatonin production drops, the brain's master clock weakens, deep sleep decreases, the body's ability to regulate temperature at night becomes less efficient. These aren't vague complaints, they're measurable biological changes that require a different approach than what worked at 40. And that's precisely what this video is. Not generic sleep advice recycled for an older audience, 15 specific, science-backed ways to address what's actually changing in the senior sleep system, starting tonight. Let's go through all 15. Tip 1. Understand why your sleep clock has shifted earlier. Everything starts here, because if you don't understand what's happening to your internal clock, none of the other tips make complete sense. As we age, the body's circadian rhythm undergoes what sleep scientists call advanced sleep phase. The master clock in the hypothalamus, the suprachiasmatic nucleus, runs slightly faster and loses amplitude, meaning its signals become weaker and less precise. As a result, melatonin begins rising earlier in the evening. Core body temperature dips earlier. The pressure to sleep arrives hours before you'd actually like it to. This is why many seniors find themselves genuinely, uncontrollably sleepy at 8 or 9 p.m. and then wake feeling done with sleep at 3 or 4 in the morning. It's not weakness or poor discipline, it's a measurable phase advance, the biological equivalent of your internal clock being set 2 hours ahead of where it used to be. The practical first step is simply recognizing this. Your problems aren't random. They're predictable consequences of a shifted clock. And a shifted clock, unlike a broken one, can be recalibrated, which is what the next several tips are designed to do. Knowing your chronotype, your individual timing tendency, helps you work with your biology rather than against it. The goal isn't to fight the early sleepiness every night. It's to gradually shift the entire window to a more livable schedule through targeted biological signals. Tip 2. Apply the caffeine fading technique. Here's a fact most people don't know. Older adults metabolize caffeine approximately 33% more slowly than younger adults. The liver enzyme responsible for breaking it down, CYP1A2, becomes less efficient with age, so the half-life of caffeine, which runs around 3 to 5 hours in younger adults, can stretch to 6 to 10 hours or longer in seniors. That afternoon cup of coffee that never bothered you at 45 is still significantly active in your bloodstream at bedtime. It's suppressing adenosine receptors, reducing deep, slow-wave sleep, and fragmenting the second half of your night, even if you fall asleep fine. The sleep is happening, but the restoration is partial. The caffeine fading technique addresses this without requiring you to give up the ritual entirely. Over 1 to 2 weeks, gradually replace your regular coffee with a blend of decaf, starting with about 3/4 regular, 1/4 decaf, then shifting to half and half, then mostly decaf. The habit, the warmth, the routine all remain. The pharmacological interference slowly disappears. Most people who apply this consistently report noticeably fewer nighttime awakenings within days of completing the fade. The general guideline is to have your last caffeinated drink no later than noon to 1 p.m., accounting for that extended half-life. Tip 3. Stop letting the afternoon steal your night. Around 1 to 3 in the afternoon, your alertness naturally dips. This happens in everyone. It's a built-in circadian trough where both sleep pressure and core body temperature fall simultaneously. In seniors, this dip is amplified. Low activity levels, the physiological shift of advanced sleep phase, and post-meal blood sugar fluctuations all pile on top of each other. The result is an almost irresistible pull towards sleep in the early afternoon. And many older adults give into it, sometimes for an hour, sometimes longer, sometimes without even fully realizing it happened. The problem isn't the dip itself. The problem is what a long, unstructured nap does to your nighttime sleep pressure. Every minute of deep daytime sleep burns through the adenosine buildup your body needs for restorative nighttime sleep. A 90-minute afternoon nap doesn't just shift things around, it actively depletes the biological fuel that drives deep sleep at night. The best response to the afternoon dip isn't a long nap, and it isn't white-knuckling through with more caffeine. It's getting outside into bright light, taking a short walk, or engaging in something social or stimulating. If you need to nap, keep it under 30 minutes and set an alarm. That's short enough to restore alertness without raiding the sleep pressure you're building for the night. Tip 4. Reduce what's fragmenting your sleep from the inside. As we age, the brain generates more frequent microarousals during sleep, brief activations of faster brainwave activity that interrupt deeper stages without necessarily waking you fully. The arousal index, which measures how often these happen per hour, often climbs from fewer than 5 in young adults to 20 or more in seniors. You may never know they're happening, but your body does. Each one pulls you out of slow-wave sleep. Each one represents restoration that doesn't happen. You cannot fully reverse this neurological change, but you can remove every external trigger that amplifies it. Pain from an old or unsupportive mattress causes positional microarousals all night. Noise from traffic, a snoring partner, or a ticking clock triggers auditory arousals. Temperature discomfort, being too warm or too cold, activates the thermoregulatory stress response. Each of these adds to a total arousal burden that may already be elevated by the biology of aging. The practical approach is environmental surgery. Identify every external arousal source in your sleep environment and eliminate it. A mattress that's 7 or more years old has likely lost the support and pressure relief it once offered, and the cumulative effect on your joints and spinal alignment over 8 hours of sleep generates more microarousals than most people would guess. Address these one by one and track the results. Tip 5. Engineer your sleep environment properly. On the subject of environment, this deserves its own dedicated tip because the details matter and most people get at least one of them wrong. Temperature first. Your core body temperature needs to drop to initiate and maintain sleep. A cool room, around 60 to 67 degrees Fahrenheit for most people, supports that drop by allowing heat to dissipate from your skin. Breathable bedding and good airflow matter too. Humidity should sit between 40 and 60%. Dry air causes nasal and throat dryness that can trigger arousals, especially in seniors who already have reduced mucous membrane efficiency. Darkness second. Any light that reaches your eyes, including the glow of a charging cable, a street lamp through thin curtains, or a clock display, can suppress melatonin and trigger microarousals. Blackout curtains or a sleep mask are not excessive measures. If you need a path light for bathroom trips, use a red-toned nightlight. Red wavelengths have the least impact on melatonin production of any visible light. Noise third. A white noise machine or a simple fan creates a consistent sound environment that masks sudden changes, the car outside, the door closing, the pipes settling, that would otherwise spike a microarousal. Consistent background sound doesn't just cover noise, it prevents the contrast between silence and sudden sound that the brain registers as a threat signal. Tip 6. Get serious about underlying medical conditions. This is the tip that has the highest potential impact for the highest number of seniors and the one most likely to be bypassed in favor of easier behavioral changes. The most common medical conditions in adults over 65, hypertension, diabetes, depression, obesity, sleep apnea, are not just health problems that also happen to affect sleep. They are direct, active disruptions to sleep architecture. Hypertension affects the autonomic nervous system activity that should quiet down during deep sleep. Diabetes disrupts blood sugar stability overnight, triggering the cortisol release that wakes people between 1 and 4 a.m. Depression alters the REM system. Obesity increases airway collapsibility. These conditions don't sit in the background. They actively fragment sleep, reduce deep and REM stages, and blunt the physiological restoration that sleep is supposed to deliver. Treating the underlying condition is not a workaround. It is the most direct path to better sleep. If you have high blood pressure and sleep problems, treating the blood pressure will improve the sleep in ways that no behavioral strategy alone can replicate. The same is true for blood sugar management, depression treatment, and weight management. Sleep and these conditions have a bi-directional relationship. Poor sleep worsens all of them, and all of them worsen sleep. Breaking the cycle requires treating both sides simultaneously. Tip 7. Address restless leg syndrome directly. Restless leg syndrome affects 10 to 20% of adults over 60, a prevalence that makes it one of the most common and most under-recognized causes of poor sleep in older adults. The characteristic symptom is an uncomfortable urge to move the legs, typically worse at rest and in the evening, that delays sleep onset and triggers repeated awakenings when it occurs during the night as periodic limb movements. The key biological mechanism is dopaminergic dysfunction, a disruption in the dopamine pathways that manage motor control and sensory gating during rest. And there is a specific nutritional connection that is particularly important to know about. Low iron in the brain, sometimes occurring even when standard blood tests appear normal, impairs dopamine synthesis and is one of the most common underlying causes of RLS in older adults. If you experience the characteristic crawling, aching, or irresistible movement urge in your legs at rest, ask your doctor to check your ferritin levels specifically. The target for RLS management is typically above 50 to 75 nanograms per milliliter, higher than the standard lab reference range. Supplementing iron when levels are low produces meaningful improvement in many cases. Beyond iron, regular, moderate exercise earlier in the day, avoiding caffeine and alcohol, and reviewing current medications for RLS aggravating effects, antihistamines, certain antidepressants, and anti-nausea drugs all make RLS worse, are the practical first steps before considering prescription options. Tip 8. Review every medication you take for sleep effects. Polypharmacy, the simultaneous use of multiple medications, affects the majority of seniors, and many of the most commonly prescribed drugs in older adults directly interfere with sleep architecture in ways that neither the patient nor sometimes even the prescribing physician are fully aware of. Beta blockers, commonly used for heart conditions and blood pressure, suppress melatonin production and can trigger vivid nightmares. Diuretics taken in the afternoon or evening cause nocturia that disrupts sleep 2 to 4 times per night. Certain antidepressants have activating properties that delay sleep onset or fragment REM sleep. Steroids generate physiological jitteriness, and over-the-counter sleep aids containing antihistamines, like diphenhydramine, carry substantial risks for seniors specifically. Next-day cognitive impairment, confusion, increased fall risk, and a growing body of research linking cumulative anticholinergic drug exposure to dementia risk. The practical step is a full medication review with your doctor or pharmacist, not just asking whether your medications are necessary, but specifically asking which ones may be affecting sleep and whether timing adjustments or alternatives exist. Taking a diuretic in the morning rather than the evening eliminates several nocturia awakenings per night. Moving an activating antidepressant from evening to morning can shift your sleep latency by an hour. These are often simple timing changes with significant sleep consequences, and they require no new prescriptions, no new costs, and no trade-offs. Tip 9. Anchor your day with a fixed wake time and morning light. These two habits work as a pair, and together they form the most powerful circadian stabilization tool available to seniors. Waking at the same time every day, including weekends, including after poor nights, anchors the suprachiasmatic nucleus to a consistent reference point. This sounds almost too simple to be significant, but the research on sleep regularity in older adults is consistent and strong. Irregular wake times weaken circadian amplitude, worsen sleep efficiency, and correlate with higher risks of cognitive decline and cardiovascular problems over time. A fixed wake time is manual maintenance on a clock that's losing precision with age. The moment you wake, immediately take that consistent time outside into natural daylight. This is the light signal that the suprachiasmatic nucleus needs every morning to reset and strengthen the circadian rhythm. It suppresses residual melatonin, triggers the cortisol awakening response that produces genuine morning alertness, and starts the countdown timer for that evening's melatonin release. 20 to 30 minutes of outdoor morning light does more for the timing and quality of that night's sleep than almost any other single intervention, and it costs nothing. On cloudy days, stay longer. Through a window doesn't count. Glass filters most of the UV and blue wavelengths that do the work. Tip 10. Time your exercise for maximum sleep benefit. Exercise is one of the most reliably effective non-pharmacological sleep interventions for older adults. It increases adenosine buildup, promotes deeper, slow-wave sleep, reduces inflammation and anxiety, and improves the cardiovascular and metabolic conditions that indirectly disrupt sleep. Meta-analyses consistently confirm that regular, moderate exercise improves sleep quality, reduces insomnia severity, and increases total sleep time in adults over 60. But timing determines whether you get most of these benefits or mostly cancel them out. The reason exercise close to bedtime is problematic is the same reason warm feet before bed is helpful: core body temperature. Exercise raises core temperature and triggers cortisol and adrenaline. Your body needs time to reverse that response before sleep becomes possible. The practical guideline is to finish any moderate to vigorous exercise at least 2 to 3 hours before bed. Morning is ideal for multiple reasons. A morning walk combines light exposure, adenosine buildup, physical activity, and circadian reinforcement into a single 30-minute habit. That's 4 independent sleep-supporting mechanisms in one activity. Chair exercises, gentle resistance training, swimming, and Tai Chi all count. The key is consistency rather than intensity, and doing it early enough in the day that the temperature and hormonal elevation have fully resolved by the time you want to sleep. Tip 11. Cut off alcohol and heavy meals well before bed. Alcohol is one of the most widely misunderstood sleep substances in common use. It sedates, which is why people associate it with faster sleep onset. But the sedation is not restorative sleep. While alcohol is active in the first half of the night, it suppresses REM sleep, the stage critical for memory consolidation, emotional processing, and cognitive function. Then, as it metabolizes in the second half, it generates a rebound arousal effect that causes wakefulness, lighter sleep, and sometimes night sweats. In older adults specifically, alcohol metabolism slows, amplifying all these effects. It relaxes the muscles of the upper airway, worsening snoring and sleep apnea. It acts as a diuretic, increasing nocturia. And it interacts with the many medications seniors commonly take in ways that compound nighttime disruption. Finishing your last drink at least 3 to 4 hours before bed significantly reduces this interference. And for people dealing with fragmented sleep, eliminating evening alcohol entirely is often one of the fastest single changes to produce improvement. Heavy meals close to bedtime create a different but related problem. Digestion raises core body temperature, generates metabolic heat, and keeps the gastrointestinal system active at a time when it should be winding down. Gastroesophageal reflux, increasingly common with age, is directly triggered by lying down shortly after a large meal and produces the kind of burning discomfort that generates microarousals all night. Finishing dinner at least 2 to 3 hours before bed removes this source of fragmentation and allows the thermal decline that sleep requires to proceed unimpeded. Tip 12. Build a consistent wind-down routine. The transition from daytime wakefulness to sleep readiness takes time, and it takes specific biological changes. Your cortisol needs to decline. Your core temperature needs to drop. Your nervous system needs to shift from sympathetic to parasympathetic dominance. None of these happen instantaneously, and they happen best when you give them consistent cues to follow. A bedtime routine is, at its most fundamental, a sequence of repeated signals that your brain learns to associate with the approach of sleep. Over weeks and months, the routine itself begins to trigger the physiological wind-down, not just as a relaxation ritual, but as a conditioned biological response. The activities that work best are those that lower arousal rather than sustain it. Gentle stretching, a warm bath or shower taken 60 to 90 minutes before bed, reading a physical book, breathing exercises, or quiet music. What doesn't work is anything that keeps cortisol and dopamine elevated. The evening news, stimulating television, checking messages, or anything emotionally activating. The 4-7-8 breathing technique is worth specifically mentioning. Inhale for 4 counts, hold for 7, exhale for 8. The extended exhale activates the vagus nerve, increases parasympathetic tone, and lowers heart rate within minutes. It doesn't require equipment, training, or time. It works. Practiced consistently as part of a wind-down routine, it becomes one of the most reliable tools for quieting an overactive nervous system that doesn't want to stop running. Tip 13. Protect your melatonin after dark. Evening light suppresses melatonin. This is established, unambiguous biology. And in seniors, whose natural melatonin production has already declined significantly from its peak, even moderate amounts of artificial blue light in the evening can push melatonin onset later, reduce its peak level, and weaken the circadian signal that should be preparing your body for sleep. The specific wavelengths responsible are the blue and green portions of the visible spectrum, the same wavelengths that dominate the output of phones, tablets, laptops, televisions, and most modern LED lighting. These wavelengths activate the melanopsin cells in your retina that signal the master clock directly. When those cells receive this input at 9 or 10 p.m., the clock registers it as daytime. Melatonin stays suppressed. Alertness pathways remain active, and then you get into bed an hour later wondering why you can't switch off. The practical protocol is straightforward. Dim your home lighting in the hours after sunset. Switch to warm orange or amber-toned bulbs rated around 2,700 Kelvin or lower. Stop using screens 60 to 90 minutes before bed, or use blue light blocking glasses with a strong amber tint if screens are unavoidable. This isn't about creating perfect darkness from 7 p.m. onward. It's about allowing the natural melatonin rise to occur without artificial suppression, giving your biology the signal it needs to prepare for sleep at the time you actually want to sleep. Tip 14. Use supplements carefully and specifically. 3 supplements have meaningful evidence behind them for seniors specifically, and all 3 should be approached carefully in the right doses and with medical input rather than the trial and error approach most people take at the pharmacy. Low-dose melatonin, 0.5 milligram to 1 milligram, taken 90 minutes before your desired bedtime, works in seniors as a genuine circadian phase signal, not primarily as a sedative. The timing matters enormously. Taken too early or too late, it shifts the clock in the wrong direction. Start low. The 5 and 10 milligram doses commonly sold are pharmacological doses with sedative effects that produce next-day grogginess. At low doses, melatonin supplements in older adults are essentially replacing a hormone the body has largely stopped making at sufficient levels. Magnesium, specifically in the glycinate or threonate form at 200 to 400 milligrams before bed, supports GABA activity, the primary inhibitory neurotransmitter that quiets the nervous system for sleep. It also helps with muscle relaxation and has evidence for reducing restless leg symptoms. Deficiency is common in older adults and directly linked to elevated physiological arousal at night. Vitamin D deserves mention because low levels, common in seniors who spend less time outdoors, correlate with disrupted sleep quality and shortened sleep duration. Having your level checked and supplementing appropriately if deficient is a simple, low-risk correction. Always discuss all supplements with your doctor before starting, particularly if you take blood thinners, immunosuppressants, or heart medications. And choose brands that are third-party certified for accurate dosing. Supplement labeling is not regulated the way pharmaceuticals are. Tip 15. When nothing else works, get a professional sleep evaluation. This tip exists because everything else on this list, applied consistently and correctly, will meaningfully improve sleep for most seniors, but not for all. And for those for whom it doesn't, continuing to self-manage while an underlying treatable condition goes undiagnosed is not neutral. It's actively harmful. Cognitive behavioral therapy for insomnia, CBT-I, is the gold standard first-line clinical treatment for chronic insomnia in older adults. Not sleeping pills, not supplements. Structured behavioral therapy that rebuilds the sleep system from the inside out. It incorporates the stimulus control and sleep restriction principles touched on in this video, but in a personalized, monitored, sequenced program. Randomized trials consistently show CBT-I outperforms sleep medications in both effectiveness and duration of results for older adults, with no dependency, no withdrawal, and no anticholinergic burden. A professional sleep evaluation, either a home sleep test or an in-lab study, is the only way to definitively identify or rule out obstructive sleep apnea, periodic limb movement disorder, or other structural sleep disruptions. These conditions do not respond to behavioral intervention. They require their own specific treatments, and once treated, every other strategy in this video becomes significantly more effective because the root fragmentation driver has been removed. Medicare and most insurance plans cover sleep studies. If you have persistent symptoms, waking unrefreshed despite adequate hours, snoring, daytime fatigue that behavioral changes haven't touched, or excessive napping that feels compulsive, a sleep evaluation is the most responsible next step, not a last resort. These 15 ways work as a system. Morning light and consistent wake time anchor the clock. Caffeine fading and alcohol limits protect sleep architecture from chemical interference. Environmental optimization removes physical fragmentation triggers. Exercise timing and meal timing align the peripheral clocks in your organs with the master clock in your brain. The wind-down routine and blue light management allow melatonin to rise when it's supposed to. Medical management removes the underlying disruption drivers that no behavioral strategy can override. None of these require a prescription. Most require no equipment. All of them work through biology that is well understood and well documented. Start with the 2 or 3 that address your most obvious patterns. Hold them consistently for 2 weeks before adding more. Track your sleep, your energy, and how you feel in the mornings, not obsessively, but enough to see what's actually changing. The improvements for most people are not subtle. If this kind of content, practical, specific, grounded in real science, is what you're looking for, subscribe and stay around. There's a lot more of it coming.